Good afternoon. At the outset, I would like to thank the organizers, especially Vincent, for giving me this opportunity to stand before such an august gathering to share our findings. My talk is entitled Phytotherapy and Hepatoprotection Transition of Tradition to Technology. Since I come from India, India has got a priceless heritage that is traditional medicine. Traditional medicine is a knowledge which is passed from generations to generation, but no written text available in a form of any scientific data. It is performed world over, mostly in developing countries, and 80% of the third world population relies on this traditional medicine. Now, what is this traditional medicine? It is an age old, tried, tested, and trusted practice. Thus, it is supported by clinical data. It is described in pharmacopoeias and well established documents. And WHO also recommends and promotes inclusion of herbal drugs in National Healthcare Program. As per the estimates of WHO, 80% of the world's population depend on herbal medicine, especially China, India, Africa, and South America. 60% of all drugs are synthesized from a compound originally derived from plants. Scientific basis of the use of herbal medicine is not known to large majority of physicians. 7.5 lakh species of plants exist on earth, but only 1% of these are acknowledged through scientific studies. Recently, Ayurvedic prediction in India estimated values around US $1 billion. Global demand for Indian herbs is almost 140 billion US dollars. And total export in India, 60% of the crude herbs are exported, 30% finished product, and 10% partially prepared products to be finished in foreign countries. Thus, the demand of herbal products increases globally, and this is the data of 2015. We know that herbs, they help in detoxification. They support detoxification, reduce toxin level, and they support various detox pathways. But natural remedies are still unacceptable because of lack of standardization of the herbal drugs, maybe seasonal variation, and many other factors account for this. Lack of identification of their active ingredients, lack of randomized controlled clinical trials, and lack of toxicological evaluation. Now, I'll be talking on hepatic disorders. We all know that hepatitis, cirrhosis, and liver cancer is the leading cause of death worldwide. 2.5 million deaths they result from harmful use of alcohol, and this represents almost 5.9% of death. 5% of all deaths worldwide are the result of liver diseases. Drug-induced liver injury accounts for 10% of acute liver failure. 170 million people is infected with hepatitis C virus, and they are at the risk of developing liver cirrhosis and liver cancer. India is at the intermediate endemic level of hepatitis B, with 40 million hepatitis B virus carriers accounting for 9% of total carriers worldwide, and liver cirrhosis accounts to 13th most common death of mortality worldwide. If we see the data of this acute liver failure through drug-induced liver injury, we see that because of acetaminophen, 46% liver failures, acute liver failure is in US. Thus, the aim of the present investigation is to validate the scientific use of traditionally used medicinal plants and to strengthen the alternative medicine in hepatic etiology. We tried to delve deep into the various objectives like antioxidant defense system, cytoprotective and cell regenerating action, free radical scavenging activities, membrane stabilizing action, reversible inhibition of cytochrome P450, necrotic pathway, inflammatory pathway, recovery pattern in cell viability, and restoration of membrane integrity of hepatocytes. I'll be very brief in my presentation. Like methodology, we selected the plants, separated the plants, then identification of isolated compounds, evaluated through model hepatotoxicants, then production of herbal formulation, then the dried extract were converted into tablets, liquid into droplets, and this into soft capsules. The entire experimental design was like this, like initially we evaluated the antioxidant properties of the herbal plants, then the selection of the optimum doses, then the evaluation of those drugs with specific hepatocellular markers in subchronic and chronic exposure, and finally the mechanism of recovery. As far as when the liver is considered, we took 4 hepatotoxicants, phase 1 CCl4, acetaminophen phase 2, alcohol, and anti-TB drugs, because TB is another major cause of liver failure, because the treatment of TB drug is not continued once the liver failure is there, and so alternative medicine plays a very important role in continuation of these anti-TB drugs. This was the overall evaluation of test drugs by following markers. We checked the excretability of the liver, cholerectic activity, various liver function test, then markers of oxidative stress, GSS cycle, drug metabolizing enzymes, histopathological changes, DNA damage, pro-inflammatory markers, anti-inflammatory markers, and then cell viability through SRB and SA, and then cell cycle analysis. So, anti-inflammatory, immunomodulatory, and antioxidant activities of the liver were studied in a holistic manner. These are the various hepatotoxicants with different doses. We have screened almost 20 plants. These are the names of the various plants. Here I'll be presenting in short about these 6 plants which we found comparatively more effective in this initial screening. This is the first slide showing the therapeutic effect of Rosa damascena and Artemisia and CCl4 in intoxicated rats. Since we all know that these are the liver markers and liver injury results in the release of these intracellular enzymes, here we see that Rosa damascena shows significantly effective activity when compared to Artemisia in CCl4 intoxication. Then we went for acetaminophen in oxidative stress. These are the various enzymes of oxidative stress: SOD catalase, glutathione reductase, and glutathione peroxidase. This also confirms that Rosa damascena showed more significant effective as compared to Artemisia. Then we look into therapeutic potential of Butea monosperma and Fumaria and various oxidative markers. Here, Fumaria was found comparatively more effective when compared to Butea monosperma. This is Polygonum bistota, and the tannic acid is the active principle of this plant extract. And this slide clearly shows that tannic acid shows better results when compared to the crude extract of Polygonum. Nigella sativa. This is a slide showing the effect on drug metabolizing enzymes with the anti-TB drugs. This slide clearly shows that Nigella sativa restores significantly the alterations of CYP2 enzymes, and the effect was compared with that of silymarin, and this is against the anti-TB drugs, and so this plant can be given to the patients in continuation with the TB drugs taken by the patients. So, this phytotherapy showed amelioration against CCl4, APAP, and drug-induced liver injury. Then, what we thought of combining the various preparing 2 polyherbal formulations which are based on pharmacopoeia, and so we came out with 2 combinations, and then we named them as SD and MD. These are the 7 plants used in the preparation of SD, and these are around 11 plants which we used in preparing MD, and this was done in our own pharmaceutical production of the department. Then we evaluated the antioxidant properties. DPPH is very good when we have to analyze the natural products. So this inhibition in DPPH was significantly protected by both SD as well as MD, but MD showed better protection, and the results were compared with that of vitamin C. Then we went further for analyzing the H2O2 scavenging activity, and this is very important for as far as liver is concerned. So concentration, after increasing the concentration, the inhibition was 65% with SD, and it was around 85% with MD, and this scavenging activity was confirmed by more phenolic compounds which were present in the MD. Significant amount of phenolic compounds was present in the MD. Next, we went for the safety evaluation of therapeutic drug by evaluating the cholerectic activity. We all know that the most important function of the liver is to secrete bile, and bile acid in mammals is cholic acid. So DHC was taken as standard over here, and the bile flow and bile solids were evaluated, and we see that MD was very effective in when we compared the result with the standard, clearly indicating that there is no adverse effect on the liver cells. Next, we did hexabarbitone induced sleep time and BSP clearance test. Hexabarbitone is a reliable index for the activity of DMEs, and here we see that 72 and 76% recovery is seen, which is very well compared with that of silymarin in case of MD. MD is better than SD here also, and same is with BSP clearance test, thus clearly indicating that protective effect on CYP2 on liver microsomes was clear from this test, and increased activity of excretory capacity of the hepatocytes. It's very clear that these two drugs clearly protect the liver and have got clear excretability. Then they were confirmed against paracetamol-induced intoxication, and all the liver markers shows significant effect. When we went for ultrastructural studies, and we see here mostly all the cell organelles where this mitochondria was the crest was very clear, ER was well developed, nuclear membrane was very clear, and with the toxicant, the damage was very clear, and this was recouped with the therapy of MD in a better way when compared to SD. So MD was found effective as compared to SD if we see both the formulations, although both were effective. And so we went further in alcohol-induced liver injury, because nowadays alcoholism is becoming a very common thing in the youth. So this is, we took alcohol markers, and here we very clearly see that the percent recoupment in both the alcohol markers like alcohol dehydrogenase and aldehyde dehydrogenase was significant with the therapy of MD, and it can well be compared with the standard that is known as silymarin. Now we went for this regulatory effect of MD on pro-inflammatory cytokinins, that is tumor necrosis factor, TNF-alpha, and interleukin. Here also we can very well say that MD had very good result, because with the treatment of they recovered by 92% in silymarin, and 89% was seen with the help of MD here. And same is the case with interleukin. Interleukin also showed 55% recovery, and this can well be compared with the standard. This was another effect on cytochrome P452E enzymes, and we clearly say that it prevents the macrosomal hepatocyte system. With the formulation protects a lot. When we went with this DNA damage, the tail length was significantly increased by the administration of the toxicant, and the polyhumble formulation recouped very well. So this protects the DNA damage of the hepatocytes. The same is here when these slides, this therapy was confirmed by light microscopy as well as electron microscopy. The entire liver histoarchitecture was maintained, which was very much damaged by the administration of the toxicant. In vitro studies, here this SRB assay was carried out to see the effect on cell viability. Administration of CHL4 significantly reduced the cell viability, and therapy with that of MD recovered this to around 83%, and this can well be compared with that of silymarin. This is the effect of MD on cell cycle progression, and here we could see, here we are concentrating only on the S phase, and this clearly shows that the cell cycle progress in S phase. Toxicant has reduced the cell population to a significant, very low number, and improved cell viability was seen with MD formulation, and thus MD promotes cell growth by inducing S phase in the cell cycle. If we go for this mechanism of action at molecular level, that we can easily say the test drugs has got cytoprotective and cell regenerating action. It protects DNA and increased cell viability in DNA synthesis. They have got membrane stabilizing action, macrosomal xenobiotics metabolism, and anti-inflammatory activities was very clear with these test drugs. And then finally we came out with like transition to technology. We came out with these two productions, and they are used as a preventive measure against the development of liver disorder at primary level. They have been taken up by the number of patients are using this. Therapeutic dose is given for a selected duration after evaluating and confirming the condition of the patient, and this is the human dose which has been selected. And now this has been used, these two drugs have been used in obstetric jaundice, purification of blood, liver function, liver and spleen enlargement, liver cirrhosis, and now at present hepatitis, patients are also being given these two drugs, and we are coming up with good results in this. Thus, here we can say this is transition of tradition to technology. We selected and identified traditionally the used medicinal plant, extracted chemical constituents, evaluated against model toxicants by using modern technology scientifically, and we came out with a hepatoprotective drug. Currently, number of patients are being benefited with these two formulations for the treatment of various hepatic disorders. Phytotherapy is cost effective, easily available to the people, so comprehensive program of identification, evaluation, preparation, and cultivation of medicinal plants should be encouraged to promote the proper use of traditional medicine. Thank you very much for your attention.
This very interesting paper is open for discussion. Question?
Can I just ask, how do you come up with the recipes for the MD and SD? Were they already available to people? Yeah. So they're available over the counter?
We have prepared in our own pharmacy, and they're available, and many patients are taking them, and they are recovering.
And this is, how did you decide what ingredients to put into each of MD and SD?
This is what I told you. Based on the pharmacopea and traditional knowledge, we came out with those plants.
So it's based on the tradition that you chose for.
Yes, question? We have to the other microphone. Sorry.
I was asking what is the timing between paracetamol administration and the drug administration. Are they administered together, or you administer the drug after some time?
We have done both preventive and curative studies. In preventive studies, we have given after the drug treatment, and in curative studies before. Both the studies have been done.
Okay, and in both cases, these herbal extracts prevent the protein modification by paracetamol. Yeah, but what I'm asking is whether they, in both cases, they prevent or revert the protein modification by paracetamol. Yes, thank you.
Any other questions? Yes.
do you choose the way that you prepare your extracts? I mean, what kind of is phenolic, alcoholic, or just water? To get the extract.
When we go for formulation, that is in Unani concept, we go for only. When we go for Unani concept, we go for only water extracts. Water. Otherwise, we go like ethanol, methanol, complete gradation of the extract. All forms of extracts.
And then
selection. See, what we do is selection of the extract is like initially we go for 10% alcoholic extract, 20% alcoholic extract in the initial screening. And the best in screening, the best results, if we get from 80% alcoholic extract, then we standardize that for different doses. There's a set procedure, papers published, how you have to evaluate the extract in a standard way. That has been given by WHO as well.
Pardon?
The standard procedure has been given by WHO. We follow that.
I see. And are you trying to get fractions and identify the main compound?
Yeah. The tannic acid was a fraction of polygon.
It's a red pure.
Yeah. So we have identified active components of those plants also, and then in initial screening we have did both. If the crude is more effective, we will not go for active compound. If the active compound is more effective, we'll go for active compound. Thank you.
Thank you.
Thank you again. Let's give another round of applause to Dr. Shukla for a very interesting presentation.